moving straight on, I'll pass on to Rachel. So next we've got Rachel Meacock. Rachel's a senior lecturer in health economics at Manchester University. Rachel's going to talk to us on how economic evaluation has been adapted for service delivery and organisational change. So over to you, Rachel.
Hi everyone. So my name is Rachel. I'm going to talk to you about how some of the methods that Seb had spoken about, the kind of core economic evaluation methods, have been adapted for situations that actually a lot of you, it might be really relevant for the stuff that you do in your ARCs. So evaluating interventions where it's kind of a change to the way that services are delivered and the way that they're organised. So just to recap on what Seb said, so economic evaluation provides us with a framework to assess the costs and the consequences of healthcare programmes. And it's all about informing decisions about what the best things that we can do with our scarce resources. It's about choices and it's about trade-offs. Just to say that you'll notice the language that I'm using is very much kind of health and healthcare. And that just reflects the facts that this is where the origins of the methods come from. So they do very much come from kind of an NHS perspective and evaluating interventions in healthcare settings where we are, the outcome that we're interested in is health. Clearly now we're moving much more to appreciating the importance of evaluations in other sectors. And I think particularly relevant for ageing and frailty is obviously going to be social care. Other people will pick up on that, but I'm going to kind of be sticking mainly to a health setting. So, no evaluation is ever simple, but as Seb alluded to, talking about where the economic evaluation methods have kind of traditionally come from something you might have heard of called health technology assessment, or HTA. And so it wasn't exclusively, but the methods have kind of come from the evaluation of drugs. And as we've said, often in a kind of randomized controlled trial setting where we've got primary data collection. So we've gone out and we've collected data from the people receiving the treatment and the comparator group. And Seb covered the NICE reference case, which is an incredibly prescriptive thing. It's a very strict set of rules on exactly how you should do your evaluation. And as we look at services, we really have to move away from that kind of strict set of guidance and like recipe book. So changes to the way that we organize our services, the way we deliver them, the way we finance them, right up to the top to kind of health policies, and they're not covered by that NICE guidance. So they're not covered by that set of rules, and they don't undergo mandatory assessments for cost effectiveness. So if the NHS is going to fund a new drug, it has to go through that NICE process and show that it offers value for money. A new policy can just be introduced and it doesn't have to go through that assessment. And the same way that a hospital can also just introduce something that they want to do, they'll probably go through a business case, but they haven't had to do that strict assessment of cost effectiveness. But then, often we'll get requests in our ARCs and will come to us and we'll be asked to evaluate this sort of thing. And it poses some additional methodological challenges when we move away from the kind of traditional NICE setup. So just to make sure that we're on the same page and you know what I'm talking about when I talk about a service intervention, for example, a great example, I think, of an economic evaluation of a service intervention was done by the team at UCL, and this was about centralising stroke services. So previously, stroke services were provided by every hospital in the country, but there's quite a lot of evidence that showed that better outcomes for patients could be achieved if we basically had these specialised centres. So we really concentrated our expertise and we tried to send patients to these few hospitals that really had all of the cutting edge expertise. But that might involve sending them further, but we basically sent people to a few places rather than everywhere. And so obviously that's a big change in the way that those services are organised and provided, with lots of different things going on. There's a long care pathway for stroke. And so that's kind of a really good example of what I'm talking about. And I think for ageing and frail patients, the kind of new thing, although some of you know it's not really new, but is virtual wards. So basically the notion that now, instead of providing care for patients in a typical physical hospital ward, there's a lot of moves in the NHS to provide virtual wards where people are actually in their own homes and they're remotely monitored by healthcare professionals. And again, that's a total reconfiguration of the services that are being provided. And so that's what I mean when I'm talking about service evaluations. So what makes them different? Why can't we just take those nice rules and kind of apply them? Any of you who've tried to do these sort of things will know that the real world is just really messy and it's really complicated. So a lot of the time, these service interventions, they're implemented at a much higher level. So they're implemented at the level of an organisation or a system. So they're not targeted at individuals. So it's not, very simple example, should we give patients a statin or not? That's a kind of very simple intervention where we just give it to the person and that's kind of it. Whereas this is kind of changing the entire way that the hospital provides services. And so with that, it can be a lot harder to identify the effect of the intervention and really say that it was because of what we changed. So, we changed something up here at the hospital level. Loads and loads of things happen to those patients. We try and look at their outcomes, and we're really trying to attribute the change in their outcomes and say it's definitely because what we changed in the service. And so it's kind of a more diluted between those two things. And the effectiveness of these interventions is so heavily dependent on other areas of the system, the context in which they are introduced and the human element. So a lot of the time we'll find that changes to service interventions can really work well in one setting. So for example, virtual wards. If that is just taking the group of patients that would have been in the physical hospital ward, it's caring for them in their homes when they may be less likely to, acquire a hospital infection. But the nurses don't have any extra workload. They're all just monitoring them from the hospital. Maybe it works great. If we've got patients in virtual ward, because we've got the hospital ward still full and we've got an extra load of patients in their homes, the ward team may not have the time to really monitor the patients at home. And so in that instance, virtual wards might not be great. So you'll see they can really depend on context, and we really need to try and figure out what is it about the intervention that works and maybe why hasn't it worked in some areas. And I suppose just to say that today, I'm not going to give you all the answers to kind of exactly how you could do one of these interventions, because, as Seb alluded to, it'd take a whole day. But the first step is to think about any of these challenges. If you're tasked to do one of these evaluations or think about one, first step is to think through these challenges and kind of how are they going to apply in your setting, and that'll help you think about how you could do your evaluation. I'll point you to loads, the slides are going to be shared, and I'll just point you to loads of kind of further reading that if you wanted to go and do these things, these could provide you with them, more guidance. Service interventions are also different because the decision context is really different. So whilst NICE make a decision about whether a product is value for money or not, NICE don't have to balance the books. So NICE don't need to find the millions of pounds to fund that new product themselves. They just say it's cost effective. It's kind of up to the NHS to then fund it. In a service evaluation, those resource constraints are really real. If I'm trying to persuade my local hospital to introduce my intervention, they're going to say, well, here's my staff team, what do you not want these people to do so that they can do this new thing? And so I think you might be facing very different and decisions that are much closer in your face. Service interventions also, and you really need to think about this, have indirect and unintended consequences which span the system. So because everything's so interlinked, you kind of change one thing here, it's going to have like knock-on effects for lots of other people. And so we often need to widen the scope of these evaluations to make sure that we assess the full impact of what's going on. As we've alluded to, these are very rarely tested through randomized controlled trials. So if we've got a trial, it's very easy for us to attribute through the randomization process that we know that any differences between our treatment and control groups are because of the intervention. That doesn't really happen in service interventions. They just get introduced. Quite often someone will come to you 2 years later and ask you to evaluate it. So you've really not been able to collect any data. And so Chris is going to do a great talk later on kind of how you deal with those challenges. So I won't really cover them, but just to say they're a huge challenge in this area. So how can we overcome these challenges, and what have people kind of done to do these evaluations? So as I alluded to, every intervention and every evaluation is different. And so there is no rule book yet. But yeah, think through these challenges and think about how they apply to your specific situation. Some are going to be more of an issue for you than others. And I'll point you to some guidance. And then, yeah, Chris will cover the non-random introduction later. So I'm going to cover two main areas where I think we have made quite a bit of progress in the area. So the first one, and Seb talked about this, was kind of outcomes and how we can, when we often don't have primary data collection, so we haven't been able to give the EQ5D to people and look at how our intervention has affected that, how we can still assess the impact of service evaluations in this kind of common metric of a QALY, so that we can do those trade-offs between whether these interventions are worth the money. Just to say, you will probably want to look at other outcomes as well. So, you know, if you're evaluating your service intervention, you're probably still going to want to look at the outcome, the intended outcome. So, you know, if it was about quality improvement for patients with heart attacks, for instance, and it was targeting the amount of people who are given the correct drugs on arrival, you're probably still going to want to look at whether it achieved that aim first of all. For these group of patients about kind of aging and frailty, you know, intermediate outcomes might be really relevant here. So things like pressure ulcers for these patients, you know, the number of falls, the cases of dehydration, these might also be really relevant. For hospital interventions, we often look at readmissions and length of stay, both because they are relevant outcomes for the system and for patients, but also because they're really easily available in the data. And so when we are relying on this secondary data, we often have to kind of, you know, do with what we've got. And so these are kind of easy to calculate with hospital data that we tend to have available to us. Information on mortality is also often available, and obviously such an important outcome. So we'll quite often look at that. But to do a full economic evaluation and be able to compare your intervention to other demands on healthcare resources, you do want to try and get your impacts in terms of the QALY if you can. Obviously, this is for NHS interventions where health is the kind of thing we're trying to maximise. And I think in the area, there's been three main developments of ways you could do this. So whilst there isn't really primary data collection of the EQ5D, there is one exception. And that's for patients with certain types of surgeries. So patients with hernia surgeries, varicose veins, and hip and knee replacements. The NHS actually did have this huge data collection exercise called PROMS. And so if you are looking at anything to do with these patient groups, there's actually EQ5D data from millions of these patients. And so if you were doing an evaluation in that area, that could be a great resource of primary data collection for you. Obviously, most of us are not going to be looking at those patient groups. And so there's two kind of indirect ways that we might want to go about getting our impacts in terms of QALYs. And so something that we developed was called a Dan Quayle tariff, which I think Dan Quayle was also some American vice president who couldn't spell potato or something. So maybe not the best name. But this is basically, if you've got an intervention that has targeted, that has significantly impacted mortality, then basically we've kind of got this indirect way of saying, okay, well, if we saved this number of lives, we've averted this number of deaths, we can estimate the QALYs that would have been associated with that gain. So basically, kind of, we know the life expectancy of patients, and so if we've prevented those deaths, we can tag this tariff on, and it gives you an indirect estimate of how many QALYs gained. And that's been applied to COVID patients. So that's one option. Your other option is economic modelling. So Seb didn't really go into this, but in your kind of standard economic evaluations, you'll have trial, and the trial will do the short-term impacts on costs and benefits. And they'll quite often be supplemented with an economic model at the end, because we don't tend to track patients 10, 15 years into the future with trials. And so that economic modelling basically takes estimates from the literature and kind of combines them, and there's no reason why you can't do that again with with a service evaluation. So you've kind of got your short-term evaluation using your administrative data, and then you can supplement that with estimates from the literature and do some modelling. So for example, if we have averted falls, there'll be some estimates in the literature about the kind of quality of life impact of a fall, and so you can use that. And yeah, these slides will be made available. So if you're interested in any of these methods, kind of further reading on how you could do that. And the bottom one, I think, is, yeah, a great example from the team at UCL about how they kind of did their service evaluation using administrative data and then did some economic modelling at the end to get a full economic evaluation out. The second area where, as I highlighted to you, is a real issue for service interventions, and I think hopefully we've made a bit of progress recently, is accounting for spillover effects. So as I alluded to earlier, spillover effects are basically any impacts on costs or outcomes other than those specifically targeted by the intervention. So you might know them as unintended consequences. So they can be positive, and that means that more patients have benefited from our intervention than was originally intended if kind of quality improvement spreads. So for example, if we had an intervention in the emergency department that was really about quality improvement for heart attack patients, but actually the healthcare professionals could kind of take some of that learning and maybe they've applied it to other patient groups who've come in, so patients with stroke, then if we didn't capture those wider benefits, we might not think our intervention had enough effect to be cost effective, but actually we might, if we capture that full spread of quality improvement, then actually it might have been a worthwhile intervention. On the flip side, spillovers can be negative, so particularly if more effort is allocated to some patients at the expense of others. So with the same example, if we've got an intervention that's everyone's really focusing on patients who've come in with heart attacks and really improving the care for them, but if that means that other patients in the emergency department are left to wait longer because everyone's focusing on the heart attack patients, then that could have a negative effect on other patient groups. And again, we need to capture all of those effects to really know the full impact of service interventions. In economics speak, whether your spillover is positive or negative is going to depend on whether the tasks are complements or substitutes. Basically, that means whether the things that you're getting people to do kind of go together or where they're pulling them apart. And so, yeah, why are they important? So if you're going to do an evaluation, there's two reasons why you need to worry about spillovers. So first of all, in your evaluation design, so as I've alluded to, kind of you might need to widen the scope of your evaluation beyond the targeted outcomes and the targeted groups. Because if you don't get all of the impacts on the costs and the consequences, then you might end up either under or overestimating the true impact of the intervention, and so making an incorrect recommendation about whether it really was worth the money or not. And another thing that obviously is going to be really relevant to what Chris speaks to later is about carefully choosing an unaffected comparator group. So if we've got spillovers then onto a patient group, we can't use them as the control because it's going to bias our estimates. And so a wonderful colleague of mine has developed a framework that's come out recently that hopefully is really helpful just in terms of that thinking. So if you're planning your evaluation, you go through the steps and map out like, okay, well, what outcomes might be affected for who, or what level that spillover might occur. And so hopefully that's a really useful resource for planning and undertaking your evaluation to check that you're getting all of those impacts. So to conclude, service evaluation is really messy, it's really complicated, and there is no rule book. There's been quite a bit of development over recent years in how to evaluate healthcare service interventions in a manner that's comparable to traditional health technology assessment. Obviously, for us, evaluating costs and benefits of health and care services is going to be really important. And I think looking at social care, probably you face some additional challenges and require some further adaptations, but hopefully the developments made for kind of healthcare service evaluations provide a building block. And then some of the other presenters will talk to you later today about social care interventions and that wider perspective. And then, yeah, the slides will be available and there's some more general reading for you in there. But yeah, thank you very much.